Welcome back to Decode Healthcare. I'm Harshal. Now, in our last explainer, we tackled the intense complexities of acute pulmonary failure, specifically ARDS. But today, we're transitioning straight from the lungs right up to the brain. Think about this for a second. During an acute stroke, 1.9 million neurons die every single minute. Yeah, you heard that right, 1.9 million. That staggering fact is exactly why today's topic, acute cerebral vascular failure, is so absolutely critical. We're going to break down the clinical presentation of these strokes, and then we'll map out the exact ICD-10-CM specificity you need to accurately document these life-threatening events.
Delay equals survival unlikely. This isn't just a catchy phrase. It's the absolute foundational rule of emergency medicine. When we're dealing with acute, life-threatening conditions, unstable vital signs are a massive red flag. They're telling us a critical system is failing. And when it comes to the nervous system and acute stroke, time is quite literally brain. Every single minute that passes without an intervention means those brain cells are being deprived of oxygen and glucose, which leads directly to irreversible cell death.
Okay, let's dive right into our roadmap. We're going to cover neurovascular emergency red flags, acute ischemic stroke, brain hemorrhages, specifically ICH and SAH, decoding the ICD-10 stroke guidelines, and finally avoiding critical coding pitfalls.
All right, kicking things off with Section 1, Neurovascular Emergency Red Flags. Before a definitive diagnosis is even made, emergency responders rely on highly specific triage systems to guide priority resuscitation. And for neurological status, well, the red flags are stark. First up, a severe drop in consciousness. We're talking about patients who are totally unresponsive, in a coma, or have a Glasgow Coma Scale score of less than 8. Second, seizures. Specifically, a life-threatening emergency called status epilepticus. That means continuous seizures that just don't stop, or repeated seizures without any recovery in between. And finally, signs of raised intracranial pressure, or ICP. If a patient shows up with unequal pupils, abnormal posturing, or a sudden, profound confusion, the body system is basically sounding a massive alarm for an immediate life-saving response.
Moving right along to Section 2, Acute Ischemic Stroke.
So, an acute ischemic stroke is defined by a sudden loss of brain function due to a reduced blood supply. That's exactly what ischemia means. But how that blood supply actually gets blocked generally falls into two distinct camps, thrombotic and embolic. A thrombotic stroke happens when a blood clot, a thrombus, forms locally, right there in the artery of the brain, directly blocking the flow. An embolic stroke, on the other hand, happens when a clot or maybe a fatty plaque forms somewhere else in the body, often the heart or the carotid arteries. It breaks away, travels through the bloodstream, and basically gets wedged into a smaller brain artery.
And this brilliantly illustrates the real-world mechanics of it. Think of a thrombotic stroke like a roadblock that just slowly builds up right there on the highway, eventually bringing traffic to a complete halt. An embolic stroke? That's more like a runaway boulder. It breaks off from somewhere else, acts as a traveling projectile, and eventually just finds an artery way too narrow to pass through. But you know what? The end result is exactly the same. The downstream brain tissue is instantly starved of blood, oxygen, and glucose.
Now, because of that incredibly rapid cell death, emergency reperfusion has to operate on these brutally strict time windows. Let's look at a real-world case, right? Say a 71-year-old male arrives at the ER exactly 2 hours after experiencing sudden left-sided hemiplegia and aphasia. Because he's well within that strict 4.5-hour window from symptom onset, he's a prime candidate for IV thrombolytic therapy, using drugs like TPA or tenecteplase to literally chemically dissolve the clot. But if a patient misses that early window or if they suffer a massive large vessel occlusion, clinical teams pivot. They move to mechanical thrombectomy, which can actually be effective up to 24 hours after those symptoms start.
Now, what's really interesting about this slide is seeing exactly how mechanical thrombectomy acts as a direct physical intervention within that extended 24-hour window. This is catheter-based clot removal. A clinical team might use catheter aspiration, which is essentially vacuuming the clot right out using suction, or they might use a mechanical stent retriever. That's a device that physically breaks up the clot into smaller pieces and just drags it right out of the vessel. It is a spectacular, life-saving procedure, but as we'll see in a minute, it requires highly specific clinical documentation. Which brings us perfectly to Section 3, brain hemorrhage, specifically ICH and SAH.
Okay, so we're transitioning from ischemic strokes, where a vessel is blocked, to the other side of neurovascular emergencies, intracranial hemorrhages, where a vessel is literally burst. And look, not all brain bleeds are the same. Their physical locations dictate entirely different clinical pathways and ultimately different coding rules. An intracerebral hemorrhage, or ICH, is bleeding directly into the brain tissue itself. Contrast that with a subarachnoid hemorrhage, or SAH. That's bleeding into the subarachnoid space, the fluid-filled area sitting between the brain and its protective arachnoid membrane covering.
Let's walk through this matrix to clearly categorize these clinical differences. For an ICH, the main culprit is often chronic hypertension or amyloid angiopathy that ruptures those tiny small arteries. The patient usually presents with a sudden headache paired with focal weakness. Treatment here, incredibly aggressive. Emergency blood pressure control, reversing any anticoagulants, managing intracranial pressure, and sometimes even surgical clot removal. An SAH, however, is usually caused by a ruptured aneurysm or an arteriovenous malformation. The hallmark clinical presentation here is the classic thunderclap headache. Patients literally describe this as the absolute worst headache of their entire life. Diagnosis might actually require a lumbar puncture, and treatment demands emergent ICU care and highly specialized procedures like endovascular coiling or aneurysm clipping.
All right, let's jump to Section 4, Decoding ICD-10 Stroke Guidelines.
Now that we've really established the clinical realities of these life-threatening events at the bedside, let's move to the billing desk and see how this builds into a logical step-by-step documentation workflow. Because guys, you cannot code purely on assumptions. Step 1, an acute ischemic stroke must be confirmed by neuroimaging. That brings us to the I-63 category. Step 2, you have to identify the underlying etiology from the provider's notes. Was it a thrombosis or an embolism? That shifts your code to I-63.0 or I-63.3. And finally, step 3, you absolutely need the specific cerebral artery involved, like the carotid, vertebral, or middle cerebral artery, along with the exact laterality. Was it the left or the right side?
Notice how the coding logic fundamentally shifts depending on the pathology. For ischemic strokes in category I-63, we need the specific occluded artery, but for intracerebral hemorrhages in category I-61, these are coded strictly by anatomical location in the tissue. Is it subcortical, cortical, brainstem, or cerebellum? Then for subarachnoid hemorrhages in category I-60, the rules switch back to being coded strictly by the artery of origin, like the middle cerebral or basilar artery. And of course, we have entirely separate categories, like I-69 for residual deficits from an old stroke, and G45.9 for transient ischemic attack, or TIA, where the symptoms completely resolve in under 24 hours without any permanent infarction.
Finally, Section 5, Avoiding Critical Coding Pitfalls.
Understanding the codes is one thing, but applying them correctly under pressure, that's another. So the crucial point is this: your coding must match the rigorous detail of the clinical intervention. The absolute #1 pitfall we see is defaulting to an unspecified code, like I-63.9 for an unspecified ischemic stroke, when the clinical imaging clearly documents the exact occluded artery. If you do that, you're just leaving the reality of the patient's condition completely off the record. Another major trap is confusing a TIA with a true acute stroke. If those symptoms resolve in under 24 hours, it is G45.9, not I-63. Plus, failing to document laterality will render your codes completely incomplete. And lastly, never ever code an acute stroke for a patient who is merely presenting with historical residual deficits from a stroke they had months or maybe even years ago. That requires category I-69 for sequelae.
As we close out, I really want to leave you with a question to chew on. If 1.9 million neurons are dying every single minute during one of these emergencies, the clinical team is out there acting with uncompromising precision. So, is your documentation mirroring that exact same level of precision? Defaulting to unspecified codes leaves the patient's true clinical reality completely off the record. Take these frameworks, apply them to your very next chart, and ensure the full story is actually being told. Thanks so much for joining me on this deep dive. Keep pushing for accuracy, and I will see you all in the next explainer.